the floor is now open for discussion. I would like to have Dr. Tariq and Dr. Mahjouba if they are around to moderate this question and answer session.
Yes, I am Dr. Tariq from Pakistan. I am here, and I think Dr. Mahjouba is also here. If she will allow me, I don't know she or he is. If he allow me to ask the question first and to start the discussion, I will like to start. Dr. Mahjouba.
Yeah, hi. Wonderful talk with Linda. Hi, Linda. Very interesting.
Okay.
It's fantastic to be able to ally skull-based surgery and research surgery. Something very interesting you said is service to patients and future of all what we are doing. Today we are tools, we are classical tools, but maybe tomorrow we will be nano tools or something like this, which is research. Thank you for your talk. Yes, Tariq.
Thank you so much.
Go ahead, Tariq.
Yeah, I'm really happy to attend the meeting, and I really congratulate all the master teachers that they have so much precisely and accurately discussed all the things that the questions which I was having before that, before the discussion, they were already answered. But I have one question with Professor Oya, who give the description of petroclival meningiomas. That he mentioned the endoscopic approach to the petroclival meningiomas through transclival approach. I only want to know that if you have any experience of transethmoidal approach to the petroclival meningiomas. If you have this, then kindly give some tips and trades about that. Thank you. Professor Oya.
I think that Oya had to go. It was 3 a.m. in Japan. He sent me a message that he had to sign off because of surgery.
Okay, thank you. Thank you. Dr. Mahjouba, if you have any questions, you can.
No, but we can tell you that transethmoidal approach for a petroclival thing won't be required because you have an endoscopic corridors which are wide enough and you can address the things, provided they're not going laterally enough. So laterally, if the petroclival is going, then you have a limitation of carotid, which you try to do transmaxillary approach, or people have started doing the transorbital endoscopic approach, going medially, cannulating the lacrimal ducts. So these approaches can be followed if you want to go on the sides. But as transethmoidal, as classically described skull-based approach, is no longer used in the present terms.
Well, we use the transpterygoid approach as an adjunct to a lateral approach for those prepontine medial extension of petroclival meningiomas that's almost going to the contralateral side. So we use that for the retroclival portion after we do already the pretemporal approach. So it's an adjunct. It's not like a pure endoscopic approach by itself to petroclival meningiomas.
Yeah, exactly. That's the reason I was asking the question, because there were some papers which mentioned that if there is petroclival meningiomas which are predominantly on the left side, that can be approached through the right corridor, and if there is tumor on the left side, then it can be approached through the right on. Then it can be approached through the as an endoscopic direct approach. That you have cleared that it can be used as an adjunct, but not as a whole corridor and a whole approach. Thank you so much. Dr. Mahjouba, if you have any question.
Yeah, yes, I have a question to Dr. Tujir Dubey, who talked about the anterior skull-based approaches. In many instances, what we face in our context also is very big tumors, very big olfactory groove meningiomas, giant, like 15 centimeters, but patients are already blind. In these cases, what would you advise? Transglobular subfrontal interhemispheric combined approach with the 2 senior surgeons for almost 15 hours surgery, or what do you advise? I can tell you that this happens sometimes in our context, that you are so tired from let's say 7-8 hours surgery that you need another senior to come fresh and to continue the work. What do you do in these cases? Do you just close and go for another time, or do you do this 2 senior surgery?
So what happens is, if you have a transglobular approach, your approach time is minimum. You are at the tumor in 1 hour. So that is one thing. And if you have adjuncts like navigation, you can devascularize the tumor within the next within 45 minutes, you can devascularize it very fast. So whenever we do these tumors, they get over in 4 or 5 hours time, because you attack the base. There are very few cases in skull base, this thing which I have faced, where you had to really cut it and they didn't get cut, and your CUSA have to be worked at the most intense pace. But mostly they are soft and suckable, so they are removed faster. So it doesn't take more than 4 to 5 hours to do the case if you use a transglobular approach. So leaving a tumor, because if you leave the inner part of the tumor, will lead to more further deterioration of the patient because of worsening edema. And going at the second time is not possible. You can also address it endoscopically from the nose, but the problem with that will be, for such a large tumor, the defect will be very large, and it takes more time for dissection. And the frontal, the graft, the vascular pedicle graft, which has to come, it falls short for a few centimeters. So transglobular is the approach which serves that. Previously, I used to do a transbasal approach, and I found out whatever the operative field I was using it was only the transglobular as you much open, because the microscope's angle will give you all the sides and everything in the end. So do small surgery, do better results it gets, do faster.
Do small surgery or do stage 2 small surgeries rather than the 15 hours. We don't do 15 hours anymore.
Yeah.
Maybe I'm getting old. I can't do 15 hours anymore.
Yeah, but we still have these giant tumors. When I talk about, it's not even only an anterior skull base tumor. It is originally an anterior skull base tumor, but that extends even laterally, superiorly, and posteriorly to the, this kind, especially when the patient is only complaining from a frontal syndrome, not completely.
Like a giant olfactory groove meningioma or something?
Exactly. But I'm talking about 15 centimeters large and the height. And it happens sometimes that you want to go faster, but you can't see what is your posterior elements, lateral. So you need to go small, progressively, little by little, including interhemispherically sometimes, because really you have to imagine these very, because you don't see giant tumors maybe anymore, but we still see these kind of tumors from rural areas and from, very sometimes under where there is no medical coverage, or
Well, what we found helpful in this giant olfactory groove meningiomas that are more than 6, I think we have 9 and 10 centimeter in our series, is we do transorbital transcaruncular devascularization of these tumors 1 day before through ligating the ethmoidals, and our oculoplastic surgeon does that. And that helps with the timing of the procedure. I think these patients will take 8 to 9 hours maximum.
Exactly.
Giant tumors. So that's something that you can consider as well, devascularizing them earlier.
Yeah. Thank you.
You're welcome.
I have one question, Professor Me. In Pakistan, we mostly have giant tumors more than 5 centimeters in size, and there is no residual function. Artery as well as the facial nerve has already gone. What should be the policy about these tumors? What do you say about these?
For what? Vestibular schwannomas?
Yeah, vestibular schwannomas with no residual function.
That are large and
and no
Like-
residual function.
And no facial nerve function?
No facial nerve function, no auditory function.
So that's easier now for you. I mean, you will do faster surgery if you already have complete facial nerve palsy for a long time, and facial reanimation would be something that you would do instantly. So I think a retrosigmoid approach, if the tumor is very large and there is facial nerve function, we also did a stage translab and retrosig for these within 2 weeks of each other. But if you have lost facial nerve function completely, then that's a facial reanimation case.
Probably spend more
Thank
time
you.
in saving the fifth nerve.
Yeah,
Yeah.
and the lower cranial nerves.
Yeah. Thank you. Thank you so much.
Welcome.
Okay, thank you. I think we're going to wrap up if that's okay with the moderators.
Yeah.
Thank you.
Thank you. I think we need to move on. Rami.